Well, hello, everybody. Good afternoon. My name is Garrett Schmidt. I am the CEO and managing editor for VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by Roji Health Intelligence. And this one's called Creating Your Risk Reimbursement Strategy in a Time of Scarcity. And I think you will be very interested in what we're going to talk about today. So excited you're joining us. A few items of note before we get started. This is a traditional webinar format like the ones we always do, where we can't see you or hear you, but we do want to hear from you. So we are going to have a time for some Q&A towards the end. So if you have a question at any point throughout the presentation, you don't have to wait until the Q&A to ask your question. You can drop that into your attendee module. There's a place for questions there specifically, and we're going to get to as many as we can during the allotted time. If we don't get to yours, because we have a lot of material to cover today, if we don't get to yours, don't worry. Someone is going to reach out via email to make sure we get your question answered. So even if we're wrapping up right at the end, go ahead and ask your question. Finally, the session today is being recorded. So if you have to drop off early, or if for the folks who weren't able to make it, or those of you who are able to stay for the whole thing, we're going to send a link to the recording here shortly after. So maybe about an hour or so after we conclude, you'll receive an email, and there'll be a link to the recording as well as to the slides, because there's a lot on the slides that you're going to want to review. And that way you can rewatch it at your leisure, share it with colleagues and friends, and we hope that you do. So without further ado, I wanted to introduce our speakers today. With us, we have Ms. Terry Hush, and she is the CEO and founder of Roji Health Intelligence, as well as Dave Halpert, and he is the Chief of Client Team. So welcome to you both.
Thank you, Garrett.
Thanks so much, Garrett. And let me start off saying hi, everybody. I hope you're in for a ride today. This is going to be a densely full informational seminar, and we hope you enjoy it. I'm going to lead off with a little bit of a discussion about your risk strategy, but first, why trust us to talk about cost to begin with? Well, I don't want to go through all the words on this slide, but we've got the experience, the technology, the data, the clients, and the history to be able to show that we really know what we're talking about here today. And what I'd like to do first is hear a little bit from you about your perspective about what you're doing now to survive under the environment we're living. And maybe we can speak to some of those elements when we get your results. So what are you doing? First of all, if you are minimizing your risk-based reimbursements right now, please answer 1. If you are partnering with CMS risk models, but that's the only payer you're partnering with, choose 2. That skeleton is symbolic of that strategy in our opinion. If you're increasing all of your payment vehicles for risk, both commercial and CMS, choose 3. And if you are really adamantly opposed to risk and you're dropping all your payers with risk-based reimbursement, then choose 4. So Garrett, are you running the poll?
I am pulling it up now, so you should all see this on your screen. Again, the question is, what are you doing to survive under scarcity? So pick one, maybe like, oh, we're doing all these things, but pick one that best applies. Is it minimizing our risk-based reimbursements? Is it participating with CMS risk payment models only? Is it increasing both commercial and CMS risk payment models? Or is it dropping all payers with risk-based reimbursement altogether? So we're going to give this another few seconds for the results to come in here. Now, looks like most people have voted, so I'm going to go ahead and close it down in another 5 long seconds. 5, 4, 3, 2, 1. All right, and Dave and Terry, or actually Terry, I don't know that you're able to see it on your screen, but I'll go ahead and read the results. We have 11% of you said minimizing our risk-based reimbursements. Okay. 16% said participating with CMS risk payment models only. 74% of you said increasing both commercial and CMS risk payment models. And then there was a 0% for dropping all payers. So that's a good thing.
That is marvelous. I'm really excited about that because it really shows that people are in motion, and that I hope you can benefit a lot from the material we're presenting today because it really focuses on number three. So I'm going to turn over the slides to Dave right now to go through a setup, and then I'll come back and talk about payer strategies.
Thanks, Terry. Yeah, so I'm going to set the stage for us all by talking about the environment and the scarcity within. Let's start by looking at how reining in fee-for-service costs. We're seeing a push from equity to insurance. As you can see from the graphs on the right, we're getting more people moving from traditional Medicare into Medicare Advantage, both numerically and proportionally. Plus, we're getting executive orders for price transparency. We're also getting some pressures from the proposed rule on the inpatient side of things like mandatory models, and also pay raises that are exceeding hospital expenses. So already we're at kind of an issue right here. It goes forward though too, because as we've seen, there have been a lot of cuts, particularly to NIH, and those lower federal revenues have global impacts on the healthcare delivery system in general. So we can see just recently about $1.7 billion have been cut from research and development, and $314 million have been cut from research, training, and career development. You can see the full numbers from the budget up there on the table on the left. So even though we have seen some good news, some of these grants have been unfrozen. Even the threat of scarcity, we know, will lead to actual scarcity. So just today, we're seeing layoffs in larger health systems, hiring freezes, deferred wage increases, delayed supply restocks, and then one on the patient side is treatment abandonment, because the patients are feeling the effects as well. And so what's going to happen with the treatment abandonment piece is that the treatment will eventually come. It will just be in a much more high cost environment because costs have not been controlled as time has progressed. And what we're going to see here is that since there were a lot of, like I said, the $300 million that were being cut from residency training programs, that's going to exacerbate the provider shortage in general. Even a relatively stable specialty like internal medicine, and that just came out this morning, it is the fourth least specialty, or the fourth lowest specialty in terms of attrition, expecting people to quit. And but even with that, we are going to see an outpacing of supply of internal medicine providers compared to the demand, particularly as we see 700,000 students poised to lose Pell eligibility, the elimination of grants and updates to loan borrowing limits and other loan initiatives, and then finally the endowment tax, where even though something is earmarked for scholarship money, first it is there is a first pass that is siphoned off into taxes. And so all of this is going to exacerbate the already well-documented provider shortage. And there's going to be cuts to other cuts that will impact teaching hospitals. It's been shown by JAMA there's a cost impact with patients seeking treatment at places that are not teaching hospitals. There's higher costs in terms of excess spending, and so that's what we're looking at the chart down below. It's an overuse composite. There's also a higher mortality rate and fewer healthier days at home in non-emergency or in non-academic medical settings, and it all reduces treatment availability in general. Aside from that, we're seeing some narrowed options in the value-based care world. First of all, you're getting mandatory models, things like the team model, where you're looking at episodic costs on major procedures that require risk and can include ACO participants. At the same time, we're also seeing models that were currently available previously being cut early. Making Care Primary was supposed to go 10 years, and now it's slotted for 2. The Kidney Care First option in the Kidney Care Choices model, that has also been eliminated a year early. And then the result is going to be based on CMS's, what they're calling the strategic direction, heavy focus on cost control. There's an understanding that value-based care is going to be here to stay, and it is going to pick up some of the gaps in what we are now in the fee-for-service world. So we're seeing a steady increase in MIPS cost measures, pushes to ACOs, pushes for ACOs to move to risk. In the first Trump administration, that was when the mandatory risk piece for ACOs came to play, and we would expect to see something similar this round. The push towards Medicare Advantage that we've discussed, and that new strategy that CMS has unveiled about a month ago, they've stated that they intend to make cost control the primary focus in any program going forward in the CMMI. So with that, how are patients' needs going to be met? Right now, we're in a phase where the administration is leaning heavily into framework, less so policy, but things like executive orders on price transparency, the restructuring of the National Institute of Health. Recently, if you followed us on LinkedIn, you could see what we had discussed with the health technology ecosystem request for information that Medicare has put out about how the system should work. And then finally, privatization that we've discussed in several models, Medicare Advantage and private health plans. Speaking of those private health plans, they are facing their own challenges. Obviously, public opinion is quite low right now with regards to things like prior authorizations. There are going to be increased audits, and those are tied to upcoding allegations. These are all serious pressures on them. And then also, most recently, United stock took a tumble after it was learned that there was a lot more utilization than previously anticipated. So they have challenges here as well. And so the trick is to figure out how patients' needs will be met in this environment of scarcity. You can see the patient feedback here. They are, I should say we, because we are all patients. We all have family members who are patients, and there is a growing demand for change. This is from a study that was published recently, the Healthcare Pulse Survey. This year, how would you grade healthcare in the United States was the question that was asked. And far and away, the C is how we're looking at it on an A through F scale. Most people aren't willing to go much beyond C. And there are a few reasons for that. In the survey, fewer than half had access to the preferred providers, fewer than half could afford prescriptions, and just over half felt that they could get the care when they needed it, and just over half felt that they could afford insurance premiums. So with all of that, going on the show.
Oh no!
There we go. All
Sorry.
right. With all of that, I still have at least one slide left here. With all of that said, there are fewer resources and a lack of coverage. And in order to bridge that gap, value-based care is going to be critical for both lowering the total cost of care, but then also to keeping patients healthy. So this is an analysis of the CBO cost estimates and economic baseline, and it was featured in America's Essential Hospitals. And what we're seeing is likely going to be an increase in uncompensated care costs. What I had alluded to previously, that patients are going to get care, however, it will be in a much higher cost setting because there is not, without coverage, it's going to be very challenging for them to get the care that they need to manage their disease effectively. Aside from that, there is the worst outcome where there are estimates of deaths that are going to be considered medically preventable. And to head these off, value-based care is going to be the way to go. So now that I've scared everybody, Terry.
Do I come into the rescue at this point? Is that what
I
my?
sure hope so. I
I don't
hope
know if we all
everybody else
consider a
does too.
risk strategy to be a rescue mission, but what we do know is that you need to calibrate that risk strategy. And we all know that if you can't line up the mouths and the eyes in this picture, it might be a hard thing to do. So we're going to take a deep dive into some of the factors that you need to think about. And those factors will open you to some alliances that may be unexpected. So when you look at your external and your internal factors, meaning how important you are to the payer in the market, and then conversely, what is your capability to live within risk limits, it might turn out that you will have some different kinds of alliances that you might expect. If you aren't following Peggy and Molly, look up Peggy and Molly on Instagram because a pit bull and a magpie have an incredible friendship. So let's look at external factors first. This looks like a simple diagram, but I'm trying to do a lot of things here. On the outside are 5 factors that describe how the market evaluates you going into negotiation. And the top scores are where you want to be. So 10 on the perimeter. If your cost is reasonable, it will be lower than the perimeter. So that's an important thing to look at. It's an inverse spread on cost, but all the other ones are straight positive. If you have exclusive clinicians, you're more attractive because they can't get to you without, or can't get to your doctors, excuse me, unless they negotiate with you. So too, if you're nice around the partnering table, people like to work with who they like. So that's good. On your size and spread and your patient risk factors, if they are good, you're going to be out towards the perimeter. If you have a problematic population, you're going to be in towards 0. So what I've overlaid here are organizations that may have the best deals in red, possible deals in yellow, and those who are difficult. So let's just look at red. I think that tells the key story here. You've got a good partnering profile, so they want to do business with you. You've got more exclusive clinicians, which is an important aspect. Cost is neutral there. So that's important to look at, is a neutral kind of cost situation where they have room to make money from you and you have room to be able to manage risk. And then your size and spread is good. So those are good factors. In the yellow, you see a smaller organization generally. The cost is good, but it doesn't make up for all the negative factors in the other spheres. There's just not a whole lot of reason to have the deal. And on the blue, it may be possible. You've got a lot of exclusivity that's positive, partnering profile is positive, but they don't have the tools to manage the risk and the spread. Those are not positive, and cost war may be neutral. It could be a deal, but these are things you have to measure. So you need to measure those 5 attributes for yourself, and here's how you do it. You can look at MIPS scores, CMS cost measures, feedback from payers. They'll tell you, where do you stand in the market. You have to take some of that and evaluate the truth of it. But on the other hand, most payers will tell you where you stand, and you will see it in how they start tiering you into their products. Looking at the percentage of non-standard, excuse me, agreements or ventures that you have, how easy it is to sit across the table from them, special projects, those are indications of whether they like to do partnering with you, and that will weigh into how successful that arrangement will be. Now let's take a look at internal factors, and these affect your tolerance for risk internally. Can you afford it? what do you need to do to be able to make yourself afford it? And here we're looking again at exclusivity because you can control how the physicians react in an agreement to a greater extent if you have exclusivity. So therefore, that's a good score for you. A financial position, say you have an endowment that allows a cushion. So even if your costs do not look good on the outside of the scale, it may be a stretch, but here's the kicker with the blue stretch organization. There's no cost analytics and no data aggregation. So the fact that cost is not positive could put you in a vulnerable position on sustainability. If you were good, you would still have room to grow. You'd be okay on your financial position. Maybe you don't have exclusivity on your clinicians, but having the cost analytics and the tech platform and data aggregation already accomplished gives you a good leg up to be able to be sustainable under a risk arrangement. 3 strategies to avoid peril of falling off the cliff. Number 1, make reducing cost of care your goal. But the only way you can reduce cost of care and make it positive for you is by improving your patient status and lowering the patient risk. So it's a very clinical strategy, not a cost meet X, reduce services kind of strategy. This is the way you grow while you lower the cost of care. Measuring and sharing your performance with your clinicians in particular, but not only that, with your partners is an important strategy for you to be able to keep everybody on board while you reduce total cost of care. And examining your opportunities to improve those risk tolerance factors is a key item to be able to survive in a market that is really heavily focused on risk. That tolerance for risk is as much cultural as it is anything else. Whether you look at that glass as half empty or full is represented on some of these questions that you have as an example. You have an ACO. Do you also negotiate with Medicare Advantage plans through your ACO? Because if you do, you're hedging your bet. You don't believe that your patients can have a direct line to you and be successful in that ACO. Are you participating in CMS, but you're not participating in private payer models? Well, again, you're evaluating the private payer market as riskier, and so therefore perhaps your tolerance is much lower in that arena. Do you have an ACO with no downside risk? Are you trying to keep capitation as low as you possibly can? That's a strategy for hunkering down, but not necessarily for growth in the market that we're facing. It creates a kind of a circular battle here. Risk avoidance, you end up with higher cost penalties under all the different vehicles, whether it's risk or let's say the MIPS cost measures, ends you with lower revenue because you can't negotiate good deals, and you end up with greater risk avoidance. So it's just a circular man-eating machine. What that really directs you toward is a multi-payer risk strategy so you can spread your risk and really identify how your entire organization can move forward collectively towards a risk future. If you don't have a multi-payer strategy, you are really sabotaging the strength you have. You can't justify the investment in the data and tools. You can't convince your physicians who are trying to meet volume and are rewarded on volume to meet performance that is focused on risk because they can't deal with all the individual minutia of doing that. Compared to others under risk, they'll have higher costs. And most important, it really gives you no on-ramp for the market that we're in right now. And now I'm going to turn it back to Dave, and then I'll be back to talk about more specific alignment of those strategies.
Thanks, Terry. So yeah, I'm going to talk briefly about how to make a cost-effective transition to risk reimbursement, and that hourglass is certainly not there by accident. There is there is definitely, as Terry said, you need to have an on-ramp for this because it is coming. And so let's just start with the 5 foundational factors for risk reimbursement success. You need provider champions. This cannot be an effort that is seen as a top-down sort of thing. What will happen then is that, just like similar attempts at administrative control, people will do just enough that they sort of fly under the radar, but there isn't going to be any real change that's associated with it because it's not something that is believed in as a core value, and having provider champions can help to mitigate that. The next is community connections. There is a chronic staff shortage. Everybody is well aware of that, but the patients still need these services. And there are opportunities in the community for partnerships that can alleviate some of the burden and administrative burnout that your staffs are experiencing by reaching out and developing partnerships with some of these resources in the community. On the more technical side, data aggregation from all of the practices and all of the data sources available is the only way to get a comprehensive patient view. And that includes not just the data related to the claims data, but also data that is clinical from the EHR itself. So you'll be able to track things like patients who have persistently poor controlled A1Cs, for example, patients that are on the cusp of a high cost event but have not reached it yet, and gives you the access to be able to intervene before that happens. And then finally, initiatives that are going to reduce the total cost of care and per patient cost of care. There's just no way around those. So in order to do that, what you need to do is start by looking at how you've done in the past. Medicare has just announced the preview period for clinicians to look at on the Provider Compare website. If you've been participating in MIPS, how you have done. Obviously, that information is slightly different on the ACO side, but for those who are just starting this process and are still looking at their MIPS feedback, there are global and targeted cost measures, and that information is fantastic to have because that is how you are going to be scored in the value-based care world. There's going to be a benchmark, and it's going to be based on historical patient data combined with regional health data, and you will need to see how you have performed on those measures in the past. There are also metrics that are shown related to utilization drivers, so things like the number of patients that you have seen that have also wound up in the emergency department. And again, there are quality measures. Every MIPS submission needs at least one outcome measure on the quality side of things, and that can help you identify at-risk patients. The next thing to do is to bring private health plans into the mix. And I'm just going to touch on a couple of things because Terry's going to dive a little bit more deeply in that and already has done so, actually. As we've discussed, not all payers are necessarily good partners. And even if they are, is there an opportunity for a meaningful initiative here? If you're looking at a health plan who has 5 to 10% of your population, is that where you want to be really funneling all of your resources? Is it going to be a collaborative experience, or is it going to be more of a trial? And trial can certainly have all meanings of trial in this situation. Is it something where you are being essentially handed a take it or leave it platter? And that is something that can reduce clinical autonomy, and that is not a good thing. So what you need to do is look at creating a single high standard of care. Aligning workflows and preventing overload. And that is already actually getting some traction now on the inpatient rule. I know that not everybody is happy about it, but that alignment of workflows is coming through in terms of looking at Medicare Advantage patients in some of those inpatient quality metrics. And then finally, and this goes to the physician champion piece, defining your goals with your providers as opposed to for your providers. This needs to be something where everybody understands what they're doing and why. To help our clients in this journey, what we have developed are what we call value-based care episodes, and they are both primary and specialty care focused. And depending on whether or not you're looking at procedures or chronic conditions or the population at large, they were based initially on some of the APMs that we've been working with on our clients, especially the enhancing oncology model. Of course, the issue with those is that the episodes that are that we're looking at, there is always that cutoff of the calendar year, and so things are truncated and sort of if this would have gone the whole year, how long would it have gone? And you lose a lot of the impact of that. And so we've developed these that are separate from a calendar year and look at more the episode window as a whole. So you have a true window of where that episode starts and ends and where your pain points are. The data is aggregated for comprehensive views for multiple users. And as I've said before, that EHR data does highlight some unseen risk factors that would otherwise be missed. And you get the good cycle here. You get predictable revenues. Your providers, your specialty providers get better referrals. Your primary care providers get the benefit of knowing that they are referring to the right people that will lead to those improved outcomes and decreased costs. That leads to healthier patients, right back to the predictable revenues. There we are. So, as Terry had mentioned, juggling multiple models is the way to go. You can't put all of your eggs in one basket, as they say. And so the focus on each of them is going to be on controlling costs. So it's not a situation where you are trying to do something for one program that is going to be at odds with the other. You're trying to develop a single high standard of care. So just for example, let's say you are looking at Medicare Advantage and an MSSP ACO separately. Talk about contracting together later, but let's look at them separately for a moment just to illustrate. They are different populations. Yes, they're both Medicare, but with traditional Medicare, you've got higher premiums and the potential for higher or you've got higher premiums. And with Medicare Advantage, you've got lower premiums, but the potential for higher out-of-pocket costs. And so you're going to have people who are healthier, who may take that gamble and say that they think that lower premiums are going to save them money. In either case, even though they're different populations, the strategy is going to be the same. You're going to want to reduce disease progression for patients who have chronic conditions, and then identify and address risk factors before they become inpatient or emergency events, things like fractures and falls. And as I described, that's already beginning with relating to some of those quality measures on the inpatient perspective proposed rule. So I will finish my piece with 3 assumptions that will clean you out in value-based payment models. We all know what they say about assuming, and here's 3 specific ones that will lead to problems. The first is disregarding historical performance and what's behind the numbers. We know that MIPS has most people who participate in MIPS, the most recent experience report has shown that those who actually made an effort to participate did perform well. Not everybody was able to avoid penalties, but the vast majority who did participate were able to. What is behind those numbers? Is it because they had the ability to strategically select measures that painted them in the best light, or was there an overall set of good quality measures that were available that are a true representation of how the organization performed? So don't disregard historical information, but also look deeply into that. There's more than just the numbers. Next, the ability to overestimate your ability to transform that claims data into something meaningful. Oh, can we go back one?
Oops. Yep.
Thank you. You will need a partner to transform that claims data. It is machine readable. It is rather challenging to read on the human side, and there's a lot of insights that you may not recognize that you need to look for, and that's where having that partner comes into play. And the last thing that you need to avoid assuming is anything. Do not assume that your patients are sicker than others. Do not assume that your providers are a higher standard than others. Any sort of assumption that does not have a basis in a data-driven exploration and hypothesis and conclusion is something that has the real potential to pull the rug out from under you in your value-based care journey.
Okay, and let's move into the final slides now. What we want to do now is create a targeted battle strategy. And that strategy would have three components. First, you have to build your internal risk capability, and those are those factors for risk tolerance that I presented, the 5 factors. Develop your external negotiation strategy, and you just keep repeating that process through all the payer opportunities that you may have. So let's take a mini model of how that actually works in kind of a high-level flight path. First, you need to deal with the actual capability for risk. You aggregate your EHR data, you prepare value-based care type episodes and cost quality analytics that allow you to identify the costs in your organization, and then you can move into investigative data queries with your physicians by sharing that data. Then you're equipped to really participate in a payment model that provides patient-centric transactions through claims data. And that's a really important piece we'll discuss in a minute. But you need to be able to have that data. And so your choice of partners here is very contingent on the ability to meet number 3. Then you'll calculate your financial benchmarks to be able to expand your risk projects to other payers as you move through the project, and you'll involve cohorts of patients and physicians in at least one or more total cost of care improvement initiatives. A lot of detail, a few numbers here. Choose your partners very carefully for your risk, especially your initial risk programs. And here's how you measure the potential for those partners. Take a look at your current reimbursement levels and see how far off they are from through your cost measures and other detail that you have on your costs. Take your book of business and identify your risk level for patients in various cohorts, definitely by payer. Look at your prior authorization denials and policies and your claims denials for medical necessity, claims denials for other reasons, and determine them by payer where you stand with both the amount of cost that you're exerting to overturn those denials and what you're losing in revenue from those denials. Your experience from past negotiations, as I mentioned, sitting around the table is worth $1,000 in terms of actually determining who your best partners are going to be. You have to have a willingness to engage in partnership in order to make it work. And the position on patient-centered claims data is paramount. If you don't have cost data, it's very difficult to be able to work with a payer to lower those costs. Your arrangement for your overall program of risks should have capitation and episodic payment risk corridors. So address the historical areas of dispute and negotiations and revisit medical necessity decisions and how those are made and who says what. Make sure that you have the support within a payment structure for novel care strategies that you have already in your organization that you are providing for patients. Do due diligence on your costs, calculate your revenues and losses for every individual payment model, or have your data vendor do that for you. And by all means, obtain universal stop-loss coverage for your risk arrangements. Here are a couple tips on negotiations. It's a bartering situation. We've all been there on this one. I've happened to have dealt with it from the payer side and from the provider side, even from the employer side. And if you are dealing with somebody at the other end of the table that is a one-way street, kind of take it or leave it, you're with the wrong partner. I wouldn't go into a risk strategy with that arrangement unless you have a lot of boundaries around that risk. The payers must facilitate your efforts to control costs. Otherwise, it's just an uneven or unbalanced game and bartering. They have nothing that they can give you to help you succeed. So understand what you bring to the table in that discussion as well. What are you bringing that they need from you in that organization? Exclusivity, we've talked about some of the factors in the very first set of slides, but claims data is your biggest ask in those negotiations. If they tell you no, you still need to push for it, and you can, there are a lot of options for dealing with the issues that they have with provision of patient-centric claims. There's the use of a neutral party to evaluate those claims. There's the bundling of episodes. There's commitments to share data. A lot of reasons. Just don't accept a no on getting claims data. Now let's talk about what patient-centric really means. It means all claims for the patients that are attributed to you for your cost, for your risk. It covers the entire performance payment period at a minimum. If you can get longitudinal data, that would be great, but you can build that longitudinal data, so I don't think it's a big thing to ask for. Primary and specialty needs for patient-centric data may be different. If you're really controlling an episodic payment and you don't have to worry about a lot of other providers seeing those patients for the episode, it's very well defined into your services, you may not need a big, expansive all claims for every attributed patient. Data must be digitally provided in files to you. No views, no portals, no buffer between your ability to get that data and integrate it with your EHR data. It works for you if it can be integrated into a database for analytics. If it is useful enough to build value-based care episodes or some other tool that you are using to evaluate cost and quality on the same nexus. You will likely, however, need expertise from a data aggregation or analytics vendor who's already built episodes or these analytics to be able to help. So why is it essential? Well, number one, if an episode doesn't cover all the costs, you can't compare them. It's just that simple. So if you're looking at procedures and the cost of anesthesia is in and out, depending on where the anesthesiologist is actually practicing from, then those procedures are not comparable, and you will not be able to target who's higher and who's lower in costs. If patients are attributed to you, but they actually get care from another, and we see this in several payment models, for example, EOM, where we have a group of oncologists who are attributed to patients, but other specialists are actually providing the chemo agent. That cost is attributed within the payment model, and it's not controllable. So it's an important aspect of every payment model to be able to look at that attribution, but also understand the costs that are associated with that and get that through your claims. If you can't see the treatment data like medications, you don't have any agency to actually control the costs at all, meaning no agency to implement any interventions for that patient or for that overall care path. Examining cost variation in procedure needs an apples to apples, and ferreting out cost drivers, you won't know what you can't see. If the data is not there, you won't be able to deal with it. So to support your payment models for both private payers and for CMS, CMS provides full patient-centric claims data, but you don't always get it. In fact, rarely get it from the commercial payers. You need to correct that situation. Everybody establishes a negotiation list of what you want, and this is what I would put on my list. Claims data number one, not through portals. Shared analytics. I'm willing to share data with payers if they're willing to share their analytics with me. Fund support for the infrastructure you need. They should have a stake in what you're doing, especially if you are important to them. So funding a piece of your infrastructure needs, your data needs is an important. Out clauses for what exclusions that are not going to be covered by risk, agreement on shared or separate patient communications. You don't want them talking to your patients about clinical matters that you are going to be doing. And then, of course, support for improvement programs, financial and otherwise. Wrap up. It's hard to pull all the pieces together here, and you can see from the cubist diagrams that I'm likely to use today. You have to accept that scarcity is in the market, and we're going through a time in which that will increase and will push payment models towards risk. Therefore, you need to calibrate that risk strategy and be able to tolerate the risk in your own organization. Making a total cost of care reduction that you can reach by improving patient status is your strongest armament for growing your organization under risk. So is adopting a multi-payer strategy so that you can make sure that you're practicing under a single standard of care for all of your patients. Choose your your payer partners wisely, and get data and tech platform to really help you model these. We would love for you to start your journey with us. You can create growth within an environment of scarcity if you have the tools. And what we have is a platform to manage the total cost of care and payment models. And we customize that technology to you. We have obviously a lot of embedded analytics in it, but our customers tell us what they need to really look at in addition to that, and we provide that. So we'd love for you to contact us to discuss your options to manage the cost of care. And we're at questions and answers.
All right, wonderful. Well, thank you, Terry, and Dave. That was very thorough. And we do have a number of audience questions. If you do have a question that you'd like to ask either of our speakers, go ahead and drop it in now to your attendee module. We're going to get to as many as we can. If we don't get to yours, though, again, don't worry. Someone will reach out via email to make sure that we get your question answered. So in no particular order, let's go ahead and begin. First question is this. What are some recommended approaches and best practices for integrating and improving coordination between primary care and specialty providers within population-based TCOC models?
That's one of my favorite topics. And we've given a whole webinar on that. So if you dig through the value-based care exhibit hall models, you will see our webinar specifically on specialty costs. But the main thing is for both organizations, primaries and specialists, to collect data and share a lot of that data with each other in order to support that kind of collaboration. If you are an ACO and you're looking at specialists and you don't know what their cost is, it's very difficult to be able to evaluate just based on your slice of their business. In fact, it's undoable. So Specialists have an interest in benchmarking their own costs right now because they're going under risk too. And to the extent that you can help them by evaluating and using a common tool to assess costs, uh, episodes are perfect for specialists in both proceduralists and treatment providers because if you can provide them both with the cost data of cost variation by episode, but also with the differences in treatment and outcomes for the patients, then you'll see a big correction on the part of specialty groups that haven't really been paying attention to that.
Great. Next question is this. Can you elaborate more on our options and what you can provide to incorporate episode-based payments within TCOC models?
Evaluate your options. Well, there's there aren't very many options for episode-based payments. The only option really that's out there right now are under closed payment models. So there's team episode-based payments for specialists on surgical things. I expect that to ramp up quickly and grow and more procedures be in. There is the EOM, which is closed right now for cancer, and that is a treatment-based episodes. All of them require you to look at the CMS or the payer treatment model or episode costs differently than you have for your book of business. And what I'm saying, and Dave referred to this, is that the CMS episodes capture either a particular point in time, like everybody who had chemo within the last 6 months, it doesn't matter where you were in the chemo process, but it's going to be a payment model and not a cost model, meaning you can't use those episodes or the CMS data or payer data to answer the question of what are my costs and what's driving them higher or lower. In order to do that, you need to develop a definitive capture of a patient episode within whatever time frame, before surgery, aftercare and surgery, with all of the costs, all of the inputs into that episode, and compare them on all of the services so you can see whether costs were driven up because of the approach of surgery, open or laparoscopic. You can see whether costs were driven up because of complications after surgery or issues of treatment such as dehydration from and nausea and hospital admissions because of chemo. Those are the things you want to look for, is what is affecting patient care that is driving up the costs. Now, there are pure cost things too. There's anesthesia agents that are used or cost of medications. Some of those you can't change, but what you can change are the inflection points that drive cost higher because of choices in either patient selection or treatment or patient risk factors.
Great. All right. Next question, moving right along. We're an ACO and are considering negotiating with some Medicare Advantage plans. What are the pros and cons for doing so, as we have concerns about the MA's restrictions of provider choice and access?
I think ACOs and MA plan negotiations are, they're a toxic mix. You're trying to protect your access to those providers under a lower cost plan that has a history of diverting patients into other providers. So at the best scenario, you need to be able to evaluate what you're actually getting out of that MA plan for your Medicare patients before you continue on with it. If you've already negotiated with it, you'll have that history. You'll have the history of denials and prior authorizations, and you can compare that. Patients are going into that plan, those plans, because they're largely healthy and they like the extra benefits and no extra copays or supplements. It's real clear. Theirs is a price strategy, but they don't know what's behind the curtain. And behind the curtain is, if their risk factors are high, they're going to get hit potentially with some denials of care. So I think that you need to look at that and determine which way is going to work for your organization and whether you are actually helping them provide an option to lower their cost of care by choosing Medicare Advantage when they could choose you directly.
Okay. We've got one more question here. And this one is, do you think most payers are willing to work with VBC organizations to help to help achieve a risk strategy, like providing claims data for strategic evaluations, et cetera?
Again, I think it depends on the factors for you in the market. So how important are you to the payer? I can tell you that I was able to get claims data, digitized files of claims data years and years and years ago to be able to estimate costs. But I represented a very important self-insured employer. That said, all my colleagues in other employers that I sat with in groups on health, commercial groups on health, had issues in asking for claims data and they never got it. I think you have to push. And their issue is evaporating because CMS, at least, is insisting on price transparency. The price transparency is your angle to deal with the issues that they don't want exposed, which is what is the hospital down the street or the group down the street's rate compared to yours? They don't want you to know that. So address that. Address the issues of transparency that their fears by working with a method that can mask that information while giving you all the claims data. And I mentioned it briefly, which is a data vendor being a neutral party, collecting that data, transforming it into episodes so that you have all the data that can fuel your cost analytics, but you don't have to take it apart and see what's the actual price being paid to, physician group Y compared to you. That's a strategy. It has worked, and I have talked to groups who have benefited from that kind of strategy. I'm sure there may be others, and there may be others coming down the line, but those patients, if they are attributed to you in a risk strategy, you can't go into that risk strategy without knowing how to calculate their costs, or depending on their numbers without any clinical information attached. You can't change it.
Yeah. All right. Well, that is actually all the time we have. So if you have a question still that we didn't get a chance to answer, don't worry, someone will reach out to you. And if you have one right now, go ahead and drop it in. Again, someone will make sure that we get your question answered later on. But thank you, Terry. Thank you, Dave, for a great, very thorough presentation. As I mentioned earlier, we're going to be sending a link out to the recording, maybe about an hour or so after we conclude here. And there will also be a link to where you can download the slides. So I'm sure you'll want to do that, and that way you can share it with colleagues and friends, and we hope that you do. As we wrap up, I wanted to encourage you all to head over to vbcexhibithall.com. And like Terry mentioned, all the webinars we've ever done with Roji, which, oh my goodness, I don't even know how many we've done over the years. They're all there, archived in our library, and there's a lot of great material, a whole library of amazing stuff to really boost your knowledge about all of these things. And Terry and Roji and Dave have contributed a lot of that. So thank you to you guys. But they have a virtual exhibit booth there that you can also check out, and that way you can do a deeper dive on them and what they're doing in the space, and of course, reach out to them directly. Their contact information is on this last slide here. And if you wanted to reach out to Terry or Dave directly, feel free to do so. There it is. And or Leonard, and he will point you in the right direction. Or feel free to reach out to me. I'm happy to facilitate an introduction if that is easiest. But again, thank you all so much for spending your afternoons with us. Hope you have a wonderful rest of the week, and you join us on the next one. Bye bye now.
Thanks, everybody.
Thank you, everybody.
Thank you.